Welcome to RhAPPcast, the official podcast of rheumatology advanced practice providers, where we delve deep into the complexities of rheumatic diseases. I'm your host and sitting president of RhAPP, Amanda Mixon, and today we are kicking off our enlightening series focused on the role of IL-23 in rheumatic disease. In this episode, we're exploring the IL-23-17 Cascade and how these cytokines play a critical role in the pathogenesis of psoriatic arthritis, psoriasis, and also inflammatory bowel disease. These conditions, deeply interconnected through their immunologic profiles, present unique challenges and opportunities for targeted therapies. Understanding this cascade and its role in immune-mediated inflammatory diseases can really help providers in selecting the best therapy for their patients. Joining us today is a very special guest, Christy Vath, who is a dear friend of mine for many years and also a board member of RhAPP, whose expertise in immunology and overall patient care provides invaluable insights into our discussion. So, Christy, welcome to RhAPPcast, and we're so happy and excited to have you here.
Well, thank you, Amanda. I'm happy to be here and to talk about the IL-23, IL-17 pathway and how it relates to psoriatic arthritis as well as psoriasis and inflammatory bowel disease.
I really can't think of a better person to talk today because you have had such an integral role in actually the development in clinical trials. So with that, can you give me and our listeners who, if they don't already know who you are and how amazing you are, can you give an introduction on your rheumatology career, etc.?
Well, sure. I've been in rheumatology for about 20 years now, and I happen to work with a very well-known person to psoriatic arthritis. I think some of the studies here he is present on, Dr. Meese, and I have been involved in some of these studies. So hopefully some of my insight will help lead the way here.
Well, and you're downplaying yourself, I think, a little bit. When I have a really challenging psoriatic arthritis patient or really anyone in the AxSpA family, you're always the person that I call because you have done, a lot of different studies and you've treated extremely complicated patients. And so it's always super helpful. And I just know that this is really great for our listeners to have you on and hopefully the start of many additional podcasts with you where you can share some insight on other things as well. So let's go ahead and get started so that we can, really kick off this podcast and unravel the science behind these really fascinating biological pathways. And I feel like I date myself with every single podcast that I do because I'm like, well, and I've been doing this for 17 years. And so you've been doing it even longer. And, but we grew up in the time of the biologic, right? Like when we started, we only had the TNFs, which are amazing medications that have changed our patients' lives. And, you no longer see people coming in the waiting room in wheelchairs. But when I first started, people were coming in wheelchairs, they were disabled, they had destruction. So you've really seen this evolution of all these different medications too.
Yeah, I think when I first started, Enbrel and infliximab were the first biologics. So I feel very lucky because I grew up with them. And so new PAs, MPs, PharmDs to the game, I think that it's a big learning curve. So I feel grateful that I've been doing this as long as I have.
Yeah, me too. I say that all the time. Like if I were a new APP coming into this, having to know everything about all these medications, it would be so overwhelming. But hopefully listeners, especially if you're new, you can find some benefit from all of the different things that we're trying to do so that we can help you kind of ease into this. So, okay, let's get to the nitty gritty, why we're all here today. So, Christy, can you talk to me about this IL-23, IL-17 access for our listeners to get us started?
IL-23 is a heterodimer cytokine. It's composed of two subunits. So you have the IL-23P19 and the IL-12 and 23P40. So it's a pro-inflammatory cytokine belonging to the IL-12 family. So IL-12 and IL-23 are structurally similar, but IL-23 plays a different role in the inflammatory cascade. So where does it come from? Well, it's secreted primarily by activated macrophages and dendritic cells in the peripheral tissues. So think about skin, intestinal mucosa, the joints, and the lungs. IL-23's intended function is to protect against bacterial and fungal infections via inducing the differentiation and activation of T helper type 17 cells. So in response to IL-23 mediated activation, T cells and the innate lymphoid cells produce IL-17, TNF alpha, and interferon gamma. In addition, the IL-23 leads to specific T cells being refractory to effects of regulatory T cells that normally suppress their activity. So what's the take home of this? Given its integral role in producing inflammatory mediators, excessive IL-23 serves as a key pro-inflammatory cytokine in the development of chronic inflammatory diseases such as IBD, psoriatic arthritis, and psoriasis.
Wow. I mean, that is very detailed and a lot of immunology and a lot of big words that I probably would have struggled getting through. So you did a great job there. And I'm sure it was really helpful for our listeners. So let's kind of put it into context. So now can you kind of talk to me about the role of, IL-23 and 17, this access in rheumatic disease?
Yeah. So in rheumatic diseases, IL-23 and IL-17 Cascade plays a crucial role in several immune-mediated inflammatory diseases. Recall, IL-23 is a pro-inflammatory cytokine mainly produced by the dendritic cells and macrophages, and it stimulates differentiation and expansion of Th17 cells. So then the Th17 cells, in response to various environmental or microbial triggers, so think your gut microbiome, in return, the Th17 produce IL-17 and other pro-inflammatory cytokines, causing tissue inflammation and immune dysregulation. So, for example, let's think about PsA and PsO. So, PsO is psoriasis. So, dysregulation of IL-23 and IL-17 access leads to aberrant activation of immune response in the skin and the joints. And then the IL-23 promotes differentiation of naive T cells into pathogenic Th17. And then they produce IL-17A as well as IL-17F and other cytokines. What happens then is you have they recruit neutrophils and other inflammatory cells to the skin, synovial, and feces, with the end result of plaques on the skin or, say, a joint infusion. Also, other pro-inflammatory cytokines like IL-1 beta, IL-6, and TNF are induced by IL-17 further. So it just kind of amplifies the inflammatory pathway.
You know, it's super interesting, and also great job describing that, because I think it's important that we not only understand the basic science and what's going on behind, in a test tube, right? But also what's actually happening in the body and that you can see, like a skin plaque, for example, or a swollen joint. So I really appreciate your description of those things so we can kind of help to visualize it when we're thinking about different therapies for our patients. So
yeah,
let's
I was just going to add too, like in inflammatory bowel disease, that same pathway results in mucosal barrier dysfunction, recruitment of inflammatory cells, and then tissue damage in the GI tract, whether it's Crohn's, which can be from your mouth to your anus, or ulcerative colitis, which is the lower GI colon.
Yeah, I mean it's so pertinent and kind of then really helps us understand again why targeting, different therapies. So I let's do that. So let's take kind of a next step and discuss this, immunologic rationale for targeting this pathway in psoriatic arthritis and psoriasis and inflammatory bowel disease.
Well, so if you think about how big a role IL-23 is, a medicine directed at uh, impairing IL-23, think about what that might do. So we know it's efficacious in treatment of immune-mediated diseases, as we talked about PsA, PsO, and IBD. And then going back to the role of IL-23, which it orchestrates the inflammatory response by regulating the differentiation and maintenance of IL-17 cells, which is a subset of CD4 positive T cells, which we know is implicated in chronic inflammation. So IL-23 in both PsA and PsO leads to expansion and activation of the Th17 in skin and joints, which result in production of IL-17A and F. Whereas in IBD, this pathway leads to Th17 expansion and activation within the gut mucosa, and it disrupts the intestinal barrier function. So if you interrupt IL-23 signaling, then you selectively block the inflammatory cascade downstream of IL-23, and by doing that, you decrease inflammation and ultimately reduce disease severity.
Well, and I think it's so important because it also really, we think about our psoriatic arthritis patients, right? And a lot of them are a spectrum, right? So they have a little bit of inflammatory, well, not a little bit, but like they have inflammatory bowel features, they have psoriasis, they've got the arthritis piece. So definitely targeting, a cytokine that can kind of really manage all of those areas, I think is really relevant and probably why we're using this, IL-23 inhibition so frequently now. Obviously, this episode is really heavy on immunology and basic science, which, like most of us got very little of that in school. And I think, it's important though in rheumatology that we have a basic understanding of it, just because I feel like that can really help us when we're treating patients. So how do you feel understanding these aspects actually translates into patient care?
Well, I think it helps to know where you target. Like you said, there's many domains in psoriatic arthritis, and including enthesitis, dactylitis, skin and nail disease, as well as joints. And so we know that targeting IL-23 decreases that inflammatory pathway in all of these domains. You see improvement in enthesitis when treated with an IL-23, improvement in dactylitis. And we haven't talked about psoriatic axial involvement, which may be a bit different than your true non-radiographic or radiographic axial SPA. So there may be a difference there. And there are some studies that we'll talk about that do show that there may be actual benefit in the spine as well.
Yeah, I think, again, I think it's just important to recognize that targeting, this particular cytokine seems to hit, to your point, more than one domain. And I think that that's, again, understanding the basic science and the immunology can help you as you're talking to patients, which I'm curious, again, you have this extensive experience and way more experience than anyone else I know in clinical trials, and kind of seeing these things at the forefront before they're even ever approved, which is, I think, so remarkable. But when you're talking to patients, Do you ever talk to them about, this basic immunology, basic science when you're talking to them about their disease or potentially the therapy?
Yeah, I do. It depends their sophistication or how interested they are, because sometimes their eyes will glaze over, and so I know that I'm talking a little too deep for them. But in general, I kind of describe it as a pathway and blocking maybe, along the way, tributaries of, say, a river, which, helps downstream effect. And so I try and use analogies when I can, which I think is helpful. And if somebody's interested in, I don't know, say someone's interested in cars, I might try and use a car analogy as best I can, although I'm definitely not automotive. So,
You could potentially use a beer analogy, for
yes,
example.
I could use a beer analogy. I might be able to do that.
I mean, again, I totally agree. Sometimes you start talking to patients because they want to understand, and then you kind of do. You get the deer in headlights kind of look, and you're like, oh, maybe I'm speaking a little too high level. But I love the idea of using, analogies, and I love the stream analogy because we always talk about that, right? Like if you target one cytokine, you work downstream at targeting other things, and so using that one, I think, is a really good, easy one that even, practitioners it can help because, I oftentimes have to teach immunology, which, to be honest, I dread because it's super complicated. And sometimes you're talking to an audience and you kind of get the deer in headlights look and, you try to make it as easy to understand. So every time I describe something, I just try to make it so that I can understand it, which a river analogy is like what my brain can understand. But I think you've done an excellent job, describing this. Is there anything additional or, that you'd like to say about this or just about talking to patients about their disease since you are such an expert in psoriatic arthritis?
Well, I think it's important when, number one, when you see a patient, you want to figure out what is their goal. They may have, say, 4 domains. They may have pretty bad skin involvement, they may have nail involvement, and then enthesitis and arthritis. And they may only have one joint that bothers them, but they may have persistent plantar fasciitis, and their skin is actually what bothers them the most. And so I try and think about the biologics we have and where they might be the most useful, or in other issues, I think about, why wouldn't I want to use this biologic in this person? Is there a family history of lymphoma? Is there, strong family history of MS? Or is there inflammatory bowel disease? Or even if it's suspected, you want to be careful with the biologic you choose. So I think I take that into account. For example, I had a patient who came in, had neck stiffness, but that wasn't his main complaint. He was coming in because he was a salesperson and his skin was involved and his nails were involved, and it really bothered him. And so we elected to actually go with an IL-23 inhibitor because that was shown to be very effective in skin and nails. For instance, in one of the studies that looked at skin versus Cosentyx, it actually was superior. So I think we think about these and we want to just kind of try and personalize medicine, I guess, as much as we can. We're still quite a ways from doing that completely.
Yeah, I couldn't agree more. I think, and that's really important to, for our listeners that perhaps are newer. It's really meeting people where they are. And understanding what is the most important thing. Because I have to say, I wasn't expecting you to say that his nails were the thing that really bothered him the most. But,
I know.
again, you have to ask. And if you don't ask, you won't know, because you're assuming it's perhaps the neck or, the SI joints or the dactylitis or whatever. But understanding that, I think, also can really help in choosing your therapy, because you know which target, like what's going to make the patient feel the best and give them the best quality of life. And, again, I think APPs do really well at really getting to know our patients. I think that that's something that is, not unique, of course, because I think all practitioners want to do that. But I think, sometimes, when we're given a little bit more time, we're really able to know the intricacies of why we might choose one thing over another thing. So as we wrap up this episode, thank you so much, Christy, for joining us and sharing your expertise, not only on the IL-23-17 cascade and its role in psoriatic arthritis and psoriasis and inflammatory bowel disease, but just your expertise in general. I mean, because again, you have been doing this for so long, and that, I think, just, really does make you an expert, but a mentor to a lot of people, and, even to me. So I really do appreciate it.
Well, thank you, Amanda. It was great to be on, and I hope it's so exciting these days to have more than just the TNFs to treat disease, especially psoriatic arthritis and even, suspected psoriatic arthritis. We'll get a lot of referrals for somebody who's has psoriasis, who's maybe been on a biologic, but they're wondering, the dermatologist is wondering if there's psoriasis involved, or even spondyloarthritis involved. And so it may be very subtle, but if you listen, you're pick that up. And it's great to learn about the different mechanisms and how we can tailor therapy better than we could even 10, 15 years ago.
Absolutely. I couldn't agree more. And what a great way to end today. And thank you so much to our listeners for tuning into RhAPPcast. We hope you found today's discussion enlightening and that it enriches your practice and understanding of rheumatic diseases. Please don't forget to subscribe to RhAPPcast on your favorite podcast platform, and also staying up to date, just in general, of the RhAPP ecosystem. So we're of course on all social media, so please visit us, rhAPP.org, on Twitter, RheumAPP, and Instagram at RheumAPP for the latest updates, insightful content, and of course exciting announcements, which we have lots of exciting announcements coming. Please join us next time as we continue to explore the other significant aspects of rheumatic diseases specific to IL-23 and IL-23 inhibition. Until then, please keep striving for excellence in your practice and making a difference in the lives of your patients, which I know you all do. Again, I'm Amanda Mixon. Thanks for tuning in and being part of our RhAPP community. Until next time, friends, we'll see you soon.